ইয়েরা সুমন আমাদের ফরেন ফ্যাকাল্টিটা কেউ জয়েন করছে?
এখনো পর্যন্ত দেখতেছি না।
আচ্ছা ঠিক আছে, আমি দেখতেছি, আমরা শুরু করে দিই, দেন আমি টেক্সট করতেছি ওদেরকে। সামির, ওদেরকে মেসেজ দেওয়া হয়েছিল, কনফার্ম করা হয়েছিল মেইল?
ইয়েস স্যার।
ওকে স্যার, আমি শুরু করি স্যার।
শুরু করো, দেরি করো, গেস্টকে বসায় রাখা ঠিক হবে না।
Bismillahir Rahmanir Rahim. Good afternoon. We welcome you all to our today's virtual academic program. Assalamu alaikum. I am Dr. F.M. Kamaluddin, Scientific Secretary of Oncology Club. We are inviting you to our regular weekly virtual academic program. We know this in the era of social distancing. We are trying to take the help of technology so that we can keep ourselves connected socially and we can practice some academic activities. So today, as a part of our session, we have finished our breast cancer session. Today we are on the third day of our lung cancer session. Our topic is role of EBUS TBNA in the management of thoracic malignancy. And today our faculty is Professor Hossain. It's an honor for me to introduce him because I witnessed Professor Ali Hossain when he became MD in 1995. When I was a student of diploma, I saw him a very young emerging pulmonologist, and I saw him growing. I had the opportunity to work with him. And today, whatever I am doing, I was inspired by him because he was one of the pioneer pulmonologists who has done so many academic activities to popularize modern pulmonology in our country. He is the professor of pulmonology. Beside, he was the ex-director of National Institute of Disease of Health. And also, he is currently holding the post of president of Foundation. So he will be talking on role of EBUS TBNA in the management of thoracic malignancy. And if now he has introduced this technology in Bangladesh, many of his students are practicing it now, but still we requested him to share his experience because we want to hear from him how they started it and what he feel about the future. Today we are expecting 3 foreign faculty. One is Abhishek Bansal, whom we met last session. He is a young interventional radiologist working in Rajiv Gandhi Cancer Institute. And we are also expecting Dr. Ullas Batra, a senior consultant of medical oncology, and he is a very focused person of thoracic malignancy, and he is now popular face as a faculty in our preceptorship and yearly program, and also our regular faculty, Dr. John Conibeer. Hopefully they will be joining us very soon, but without wasting our time, as per instruction of our president, I want to continue. So we have our president, Professor M.A. Hai, who is the patron of Oncology Club and also the president of our Oncology Club. And above all, his presence is our inspiration. Sir is always with us physically, and also he is helping us by his all the inspiration and support. Now I request as a culture to our president, Professor M.A. Hai, sir, to start formally the program. Sir.
Thank you, Kamal. Bismillahir Rahmanir Rahim. Assalamu alaikum, all the participants. My heartiest welcome and gratitude to all the participants, particularly Professor Ali Hossain, who has very kindly accepted our invitation, also to the faculties from abroad. Without making any delay, I think we should start our function. Please start it. It's open now.
So thank you, sir. Just for your information, 2 of our foreign faculty, Dr. John Conibeer and Abhishek Bansal, is already with us, and hopefully Dr. Ullas will be joining us very soon, any moment. So just
good morning all.
Hi John, how are you?
Yes.
Very well, thank you. Very well.
So we will be discussing today about the EBUS TBNA role, and after the lecture we will be asking your comment about your practice, what you do. So now just a quick recap, that housekeeping announcement. The program is totally 90 minutes. We are expecting around 15 to half an hour, 15 minutes to half an hour presentation. Then we will expect some comments from our faculties. Then we will appreciate the question answer. And then we will go for a case discussion, quiz, and vote of thanks. So as usual, we have our foreign faculties and our local presenter, and also all the participants up to assistant professor will be treated as faculties. And we will be expecting participants like the postgraduate doctors and PG students. And we will be expecting that they will be asking mainly the question, and the faculty will try to answer. And anybody is welcome to join in the discussion. And end of the day, we will have a quiz, which is a very expected part for our juniors, where everybody is allowed to join. So without going further delay, now I request our today's faculty, Professor Ali Hossain, Professor Ali Hossain, who is the president of Bangladesh Lung Foundation and also the ex-director of our National Chest Institute, to start his presentation. Professor Ali Hossain.
Assalamu alaikum and good afternoon. Thank you, Kamal, for nice introduction. Respected Chairperson, Professor Hossain, respected faculties and participants from home and abroad. Actually, I like to make my presentations on EBUS TBNA, role of EBUS TBNA in the management of thoracic malignancies. Actually, endomorphic ultrasound is a bronchoscope technique that uses ultrasonogram, visualizes structures within and around the lung. Now, we note that sampling from the mediastinum, we have got some conventional TBNA and we have got EBUS TBNA. But the difference is that with conventional TBNA, it is less invasive, but yield is variable. And all immunization cannot be sampled by the conventional TBNA. But EBUS TBNA has emerged as a technique that combined the high yield of medistinoscopy with the minimal invasiveness of the TBNA. Now it has got a lot of clinical applications. With this EBUS, actually we can visualize mediastinal and peribronchial lymph nodes metastasis, and we can determine the depth of tumor invasion of the tracheobronchial lesions. And even we can localize and diagnose peripheral pulmonary lesions. It could be benign, could be malignant. And especially it is very important for staging of non-small cell lung cancer. And we can diagnose and evaluate pathologic conditions like pulmonary sarcoma and pulmonary embolism. These are some few clinical implications which you can done with the EBUS TBNA. Now, in the thoracic malignancies, the main indications for the EBUS TBNA are the mediastinal and highlight staging of the lung malignancy and diagnosis of suspected malignancy where no endometrial is present in patients with lymphadenopathy. And one important thing is that recurrence and staging of non-small cell lung cancer after chemotherapy radiations. These are three main things where we can apply our EBUS TBNA. Now, actually, it is a biopsy procedure, needle biopsy procedure, and that has accessibility compatible with the reach of the convex flow EBUS scope. And so N1 nodes are also accessible. And the diagnostic yield is very similar to the medistinoscopy. And the core obtained by the dedicated transbronchial needle biopsy can be used for histological assessment and to determine the subtypes of the lung cancer. Even though it is very popular for staging of the non-small cell lung cancer, but it can be used for nodal staging in patients with small cell lung cancer. We all know that surgical indication for small cell lung cancer is limited to stage 1 disease. So diagnosis of N1 nodes is very important, and EBUS TBNA is very useful in this regard. So though it is very recommended for the non-small cell lung cancer, but even in small cell lung cancer, especially in stage 1 disease, it can be applied. It is reported that sensitivity, specificity, and diagnostic accuracy of the EBUS TBNA for small cell lung cancer is 96, 100, and 97.2% respectively. So even though you're telling about the non-small cell lung cancer, we can also use it for the small cell lung cancer. Another important thing is that samples obtained by the EBUS TBNA is, though it is cytological materials, we can use for this block for the tissue coagulation plot method or cell block, making this sample can be used for histological evaluation, including immunohistochemistry. So not only histological evaluation, but immunohistochemistry is possible for the EBUS sample. In combination with the immunohistochemistry, the rate of diagnosis of non-small cell cancer is very high, and the majority of these samples can be used to diagnose the subtypes of the lung cancer. Moreover, the samples can be used to test using biomarkers if we can take the adequate sample, especially detection of gene mutations an epidermal growth factor receptor, and ALK fusion genes can be done using EBUS TBNA samples. So in addition to the sample obtained by EBUS TBNA can be used for the molecular testing, which is useful for selecting appropriate candidates for molecular targeted therapy. That means that who is the candidate will get beneficial by receiving the molecular targeted therapy. Moreover, you can do the EBUS TBNA repeatedly during the treatment. When the patient gets treatment, you can do these procedures, and the samples may play an important role in exploration of the drug resistance mechanism. So the samples can also be used to test the various biomarkers using immunocytochemistry, PCR, DNA, complementary DNA, in situ hybridizations, and the technique is used for also selecting the candidate for specific molecular targeted therapeutic agents. So nowadays, the American College of Chest Physicians, they have given a guideline. EBUS TBNA is now considered the best first test for nodal staging in patients with radiological suspicious node. But the thing is that it needs appropriate training, so the clinical experience is required, and it should be used some special center, because in all center it cannot be performed. So that's why it needs a special center and special training. So now we can say that EBUS is a game changer because of the fact that initially we have to do medistinoscopy, but nowadays EBUS is enough because it is minimally invasive. Its ability to assess nearly all nodal stations, an ability to combine the diagnosis and staging in a single procedure, and yield is equivalent to the medistinoscopy. And moreover, it provides adequate tissue for the molecular analysis. Advantage is that real-time imaging permits the sampling of lymph nodes that is smaller than 10 millimeter in short axis and near major blood vessels. And it has got high diagnostic yield, and complication is very uncommon while sampling is performed in real time. It is a safe procedure, can be performed on an outpatient basis using local anesthesia and conscious sedations. And I have already mentioned that EBUS can assess a wide range of interstitial lymph node. You can see here from the figure that you can see almost all the stations and all centrally located pulmonary lesions and the high sensitivity. And several systemic reviews and meta-analysis has reported that EBUS, the sensitivity of the EBUS is 93% and pooled specificity is 100%. And in comparison with the PET and PET-CT, the sensitivity, specificity, and accuracy of the EBUS even superior in some cases over the PET. And the disadvantage is it has got definitely some disadvantage. It cannot image or sample symbiotic and paraesophageal lymph nodes. Which is one of the major disadvantage. And stability is institution specific, and it needs expertizations, and sample size is definitely smaller than the medistinoscopy. Now, let us see. If a person is diagnosed as lung malignancy, the staging is done on the basis of radiology. CT is usually used for initial evaluation of the disease. For nodal staging, the sensitivity, specificity, diagnostic accuracy of the CT is 68, 64, and 65% respectively. Now let us see what is the position of the PET. PET has some higher diagnostic accuracy over CT, and meta-analysis has shown that sensitivity of PET is 100%, but specificity is 78%. And moreover, the enlarged lymph node more than 1 centimeter, it is 82 and 93% for the normal size lymph node for detecting metastatic lymph nodes. But the lymph node whose size is 8 millimeter or less, PET becomes sometimes negative, false negative. So we can see that the patient having malignant deposit, but size of the lymph node is less than 8 millimeter, PET may be false negative. Due to such limitation, histological confirmation is recommended when nodal disease is suspected by radiologist. The overall sensitivity and negative predictive value of EBUS TBNA in medicinal staging of the lung cancer is 91% to 99% respectively. Regarding medicinal lymphoma, the overall sensitivity, specificity, and positive predictive value and accuracy is very higher You can see here from 89, 97, 98, 83, and 91% respectively. Now, there are different types of EBUS. One is radial probe EBUS, and another is convex probe EBUS. Nowadays, three types of EBUS are recommended. One is miniature radial probes, radial balloon probes, and convex probe EBUS. I will not go into detail of the EBUS procedure. I will just highlight on the ultrasound frequencies. There are two sorts of ultrasound, higher, lower frequencies and the higher frequencies. Lower frequencies has got better penetrations and less resolutions, but higher frequencies has got better resolution but less penetration. For EBUS, the frequency of the ultrasound is 7.5 to 30. Now, there are some contraindication of the EBUS procedure, especially if the patient has got cardiac arrhythmias, if the patient has got recent MI, if the patient has a poorly controlled heart failure, hypoxia, and of course, the patient who are not cooperative. And another some contraindication is the patient receiving current antiplatelet agents, current anticoagulant therapy, coagulopathy, thrombocytopenia, and elevated urea nitrogen. Now, one important thing is that how we can approach during EBUS procedure. If we find a lymph node, we see the shape of the lymph node, whether its margin is distinct, heterogeneous ecosity is there, and abundant blood flow with varying vessels, diameters, and tortuosity. The presence of at least one or a combination of these features in a lymph node was designated as the target area for the EBUS TBNA. And while multiple lymph nodes are detected in the same station, the biggest lymph node with suggestive malignant features should be chosen. Now, definitely the procedure has got some complications, especially patient may be agitated, there may be cough, hypoxia, there may be fever, sometimes pneumothorax may happen, and very rarely mediastinal abscess has been reported. And some other complications may happen during the procedure, especially laryngospasm, laryngeal edema, sometimes cardiac arrhythmia may happen. And moreover, some complications may happen because of the use of the sedation that is used in procedure, EBUS procedure, especially respiratory depression may happen, and sometimes patient may vomit and may have the chance of aspirations. Now, from this, we can conclude that EBUS is a very good procedure especially for the lung malignancy for non-small cell lung carcinoma, and to some extent to the stage 1 small cell carcinoma for the lymphoma, and for some central type of lung lesions. And the yield of the EBUS is very much compatible with the mediastinoscopy. Moreover, the advantage is that we can do the molecular analysis, we can plan the target therapy, and moreover, during the treatment protocol, we can do the EBUS to see whether the patient is developing resistance to the EBUS or not. Thank you for patient sharing. Thank you for the giving me the chance to take the opportunity to tell something about EBUS. Thank you very much. Thank you all.
Thank you, Professor Ali Hossain. I'm sure it is not a very commonly practiced procedure in our country, but after listening to your lecture, we will have some light on it. So I think before going to the question and answer, we have three foreign guests here, two from India and one from UK. So let us have their experience first. So we have an interventional radiologist, Dr. Abhishek Bansal. So I would like to request Abhishek, would you like to make few comments? Then I will go to Ullas and finally I will go to John. Abhishek.
A very good afternoon, respected panelists. And it was an amazing lecture by Professor Ali Hossain. And sir, with all due regards, I would rather request Dr. Ullas to make a first comment, and then I would pitch in, because I think that's a practice that we follow. The oncologist being the center of the patient management, and that maintains the continuity. So I'll ask sir to start with his comments, and then maybe I can pitch in.
Okay, no problem. Ullas.
Okay, a very good afternoon to everyone. And in fact, it's going to be a good morning for me. It's a Sunday. I have slept the entire Sunday morning at home and just woken up. So I think EBUS is something, we started at our institute around 8 to 9 years back. And initially there was a lot of skepticism in using EBUS, and we were not really aware of what EBUS is. And the more important thing was, since it brings an extra cost to the patient, we weren't sure. And we used to take PET scan and CT scan at the face value. But the more we have started using EBUS, life has become very simpler. It is basically, a point of getting yourself convinced about the data. If you are convinced about the data, you can do a lot of things about that. So now, any patient who is operable lung cancer does not really go to the surgery without getting an EBUS. So what we do is we get a CT scan or a PET CT scan done. If the patient is operable or the patient we think is has significant lymph nodes, we do go for EBUS initially, which can be in the same setting as almost same as what the bronchoscopy does. And yes, there is a small cost involved to it, but we have picked up so many lymph nodes which are tuberculosis. We have changed management of so many patients that, I mean, EBUS really looks like it should be a part of the regular strategy of the of our therapeutic armamentarium that we have in lung cancer. And definitely any patient who has got an operable lung cancer, we need to get EBUS done. Having said that, definitely there's a learning curve. There's a learning curve for the pulmonologist. There's a learning curve for the oncologist. But I think EBUS needs to be done. Once you are done with the initial thing, the important thing is to know what exactly it is all about, and to get it out of it should be a part of everyone. That's what I have to say.
Thanks, Ullas. Sorry for spoiling your holiday. I know it's a expensive, precious Sunday, but still I'm happy that you joined with us and shared the experience. So
I have two more this thing. I think there are two questions in the chat box over here. Who's responsible due to the EBUS? At our center, it's the interventional pulmonologist who does it. And the staging workup which we follow in our institute is, normally patient comes to us with a CT scan chest. We do a PET CT scan. We do an MRI brain. We see what our lymph nodes are there. And then if the patient is operable, we get our EBUS done. Again, very important to know, there are certain lymph nodes which can be picked up by the EBUS. There are certain stations which cannot be picked up by the EBUS. Ideally, what we should do is actually a combination of EBUS and EUS, which is done, which should be done actually. Back to you, sir.
Thanks, Ullas. So maybe we'll be coming back to you again. So there is so next question is, comments from Abhishek. So Ullas gave an idea that you people are doing great job there. Would you like to add something on it?
Yes, sir. So he's like the opening batsman for our cricket team. And as I said, sir, it is the oncologist who manages the patient totally. And we are lucky, as Ullas sir also pointed out, it's being done by the interventional pulmonologist. But there are certain centers like Tata Memorial, Bombay, where the pulmonologists are working along with the interventional radiologist for the EBUS carried biopsies. Anyways, but again, we are lucky that we have a great respiratory team at our hospital who's managing all these patients, and we've had good results. So I get involved with the picture only about a certain station of nodes that Dr. Hossain has already shown. The station 5, which is probably not accessible, the pre-aortic, the pre-vascular ones. But otherwise, as sir said, it's a part of the management of oncology patients, and really can't do without it. And not only not just about the mediastinal staging, and otherwise also for all central lesions, I think EBUS has got again a big role in diagnosing the cancers.
Thanks, Abhishek. I remember in the last week you told that you had a series of almost 1,000, and unfortunately you didn't had any bad.
Yes. So again, sir, our practice is a very combined practice. So Dr. Ullas would bring me up, Abhishek, is this lesion better accessible by you, CT guided, peripheral guided, or to the respiratory or to the respiratory team? So we are very fair in that. Again, patient matters. We individualize the sampling to the patient. So if we feel the lesion is central, the lungs are bad, definitely it's the pulmonologist who takes the lead and does the sampling initially. And if we feel it's peripheral, it's easily accessible for us, because I can tell you there are patients who have come to me post bronchoscopy or EBUS sampling, and they would say it is okay. I would not get any further treatment, but I would not want to get another bronchoscopy or an EBUS done. So there also, we need to look at that aspect of the patients also, their experience also. So, but again, it's a very fair practice. Lesions that are peripheral, easily targetable through outside, we do that. Lesions that are central are targeted through the EBUS or the bronchoscopic guidance.
So what I understand, that it is not my job, it is our job. I think that is the best way of thinking. If somebody thinks that is my job, it is a mistake. So it is a job for the patient and we need to do it. So we is a team. It is a pulmonologist, it is an interventional radiologist, and also the oncologist are in the team. So we all need to work together and identify whom to be involved at what time to get the best result. So next, John, are you there? Or would you like to make some comment? Then we'll go to the question answer.
Yeah, so in the UK, it's the pulmonologist or the thoracic surgeon who's normally conducting our EBUS procedures. And typically, within the context of our lung cancer MDT, it's a multidisciplinary sort of case discussion for each patient. So patients, through that discussion, are identified as to which ones would most benefit from having an EBUS procedure performed. In the context of surgery or, of course, radiotherapy, where I come in, undoubtedly it plays an important role in understanding which stations are involved and which stations need to be targeted, particularly in the context of chemoradiotherapy. There's also an expanding role for it in stereotactic radiotherapy. So patients who have isolated disease recurrence within solitary nodes or a handful of nodes, we can now treat them safely with stereotactic radiotherapy using fiducial tracking that's inserted under EBUS by, again, either our pulmonologist or thoracic surgeon. I'd also say, from my experience working with different clinicians, that obviously it is dependent on the clinician's skill, and it strikes me that skill is driven by the number of procedures that clinician is performing. So if they're in a busy pulmonary department doing lots of procedures every week, undoubtedly their ability to EBUS does seem to be better than people who do it ad hocly every now and again in the centres around me. But a great presentation. Thank you this morning.
Thanks, John. We have some question in the chat box. Even it was answered in the chat box, I think it will be good to have some discussion. So may I request Dr. Arman Raza Chaudhary. Arman, unmute yourself and ask the question to Prof. Ali Hossain.
So, sir, my question was, it is whose responsibility, already it is discussed, that is whose responsibility to do the EBUS, the interventional radiologist or pulmonologist, and already it is discussed.
But in our country context, Prof. Ali Hossain, sir, we would like to hear your comment that in our country context, who is actually doing it? What is the practice now?
In our country, actually, we are the pulmonologists, interventional, we are doing this EBUS in our country. Actually, not all the pulmonologists do this job. Actually, only few are actually involved with this because it's time consuming. One thing, it is very time consuming. Second, it needs dedications, and you have to find out an extra time at least for 2 to 3 hours for the patient, for the motivation of the patient, for do the procedures. And even you have to prepare the slide, you have to see whether the adequate cell has come or not. And it also needs the help of the pathologist at the same situations where the finding of the cell is adequate or not. So we are actually in cooperation with the pathologist, actually we are doing this procedure in our country.
I think, sir, I'll just add on to it. I think across the globe, it's the pulmonologists who are doing it. I think the confusion arose because I am part of the panel, I think. So let me make it clear, interventional radiologists are not playing any role in EBUS. Only because of certain laws in India, we have a strong law of PNDT to regulate the ultrasound usage because of sex selection. So only because of that, certain institutes like Tata Memorial in Bombay are involving radiologists to be a part of the respiratory team. Otherwise, it's always the pulmonologist who do it.
Thanks, Abhishek. I mean,
can I also add in, sir?
Yeah, please.
In Tata Memorial, it's either the interventional pulmonologist or the surgeons actually who do the EBUS. Prior to that, so even surgeons, they don't want to do mediastinal cut open and all, they do a EBUS prior actually.
Good. So in our country, unfortunately, the intervention radiology is not very robust yet. And even if I'm not wrong, Professor Ali Hossain can correct me. EBUS is not a very widely practiced, in very limited setup. It is practiced, and he pioneered it, and now some of his students are practicing it. But for some technical issues, I think now probably only one center is running it. Am I correct, Professor Ali Hossain?
Yes, only one center is running now.
Yeah, they started in quite a few centers, but unfortunately, in the government center, they could not continue it. But the only center is running. But I think now there is a quite good number of pulmonologists who are trained on EBUS who can really perform. Good number of your students are now capable of doing it. So is it the facility or is the demand that we are not asking for many? That's why it is not becoming popular, or it is the facilities? What do you think?
Both is important. The facility is limited, only it is done in one center. And demand is also there because demand is not that much. Even we pulmonologists, we don't see that many of the pulmonologists are referring for the EBUS actually. So it is not that much popularized in our country. I hope that in future it will be popularized because if the patients who came from the abroad, they come with the report of the EBUS. So in course of time, the physicians will be accustomed to this.
Dr.
So
Mustafa?
actually, we do not know even that EBUS is being done in Bangladesh.
Yeah, that is correct.
This was the first time I am listening.
Yes. So that is why we had done this program, sir. So we want to disseminate this information. Like you, many of us don't know that EBUS. I knew EBUS, but I didn't know that so many opportunity for us. Even in radiation, as John was telling, for SBRT, we can do a EBUS, make it confirm that it is not a node positive. For chemoradiotherapy also, not only for surgery, for even when to identify the confusional node, whether it is positive, negative, EBUS made a big role. Mustafa Aziz Shuman, there is a question from you.
So I have two more questions. At first, it was discussed in the chat box. But now I have another question. I just like to know what is the discordance between PET CT scan and EBUS, particularly for nodal status.
I have already shown in my lecture that in certain cases, PET CT may not be representative, especially if the lymph node size is less than 8 millimeter, but there is metastasis, which may be false negative. But in this case, EBUS is very helpful. So you can see that PET CT in sometimes case, the EBUS is superior than the PET CT, may not be always.
Can I comment on this, sir?
Yes, please.
Okay, so we think of PET scan as a sine qua non. We think of PET scan as a holy grail of radiology. But the more and more you use PET CT scans, the more headache it becomes. Especially in a country like India, Bangladesh, Pakistan, Nepal, where tuberculosis is so very high. PET scan is just going to show you some lymph nodes who lights up. It is the job of the interventional pulmonologist and the interventional radiologist to prove whether it is tuberculosis or not. In fact, I would say in developing countries, in our setup, Abhishek will corroborate with, we have a tumor board, only thoracic tumor board. And we have got, classical signs of malignancy on the PET CT scan. The moment you do a biopsy, it turns out to be tuberculosis. So PET scan, yes, it is good. Again, so the dictum in operable lung cancer is, you do PET scan for staging of the metastatic workup, you do mediastinoscopy or EBUS plus EUS for the mediastinal lymph node staging. So that's the dictum, and I would say definitely there are 20% discordance between PET CT scan and EBUS. If you start using it, you will realize why didn't I use it before. Trust me on that.
Thanks, Ullas. Your comment will be an inspirational, and hopefully we will be now looking for how can we do EBUS more and more. Dr. Istisfar from Sylhet. You have a question. Istu, can you unmute yourself and ask the question?
Assalamu alaikum, Kamal bhai.
Walaikum assalam.
Thank you, Speaker Professor Ali Hossain sir, for nice speaking. Just I want to know which one is better for medicinal staging, either medistinoscopy or EBUS?
Actually, medistinoscopy is a procedure. Actually, patient needs anesthesia, and you have to take incisions over the suprasternal notch, and you have to put the mediastinum. Then you have to visualize this. It is the actual procedure. It is a it is a long procedure. But EBUS is a very short outdoor basis. You can do it, and the yield is very almost same. There is no significant difference with the medistinoscopy and the EBUS. The only thing in certain situations, I have already mentioned, we cannot find the sample. Otherwise, in all the cases, EBUS is enough for the lung malignancies. So and there are some complications of the medistinoscopy, but the EBUS has got very least complications. And patients, after doing the procedure, patient can go home by walking after 1 to 2 hours. So I think that if you consider the risk of the patients and the procedures, even the financial, EBUS is less costly than the medistinoscopy, because patient have to go for the anesthetic checkup. Anesthesia should be given. Patient have to stay in the post-operative room, but EBUS does not need this. So EBUS is far more economic, and really it is better in many situations in medistinoscopy.
Thank you, sir.
That was a very critical thing, because once upon a time we used to think that medistinoscopy, because it was the teaching that in some certain station, if we don't know what is the situation, so medistinoscopy was a standard routine recommendation. But EBUS came and it has ruled out, taken the place of medistinoscope. As Professor Ali Hossain said, it's an outdoor procedure, no anesthesia, no admission, and patient can walk out with a minimum risk, almost no risk compared to, because it was an invasive procedure. Medistinoscopy is totally a surgery. It's a mini surgery, but it's a surgery. And you are going to the medistinoscope, so there is a question of infection and any postoperative complication can happen. So Debraj, I think you had a question there.
Assalamu alaikum, sir. Thank you. My question is to sir that you have already mentioned that EBUS TBNA is the best first test for nodal staging over mediastinoscopy. So I want to know that what is the best approach for re-staging, mediastinoscopy or EBUS TBNA?
What do you mean?
Actually, re-staging is only needed in some situations. Say the malignant patient getting therapy. If you find a suspicious node, then you can see that you have to do the re-staging. And whether the patient is resistant to treatment or not, you can do the re-staging. It is not a common practice actually. Only in few cases, the oncologist, if they found that patient is getting improvement, if they are getting the treatment as his per wish, so he can then demand for the re-staging basically. And again, the evaluation of the patients. So it is not a routine procedure basically.
And Debraj, to answer you, as Professor Ali Hossain said, if you want to see the response even of the neoadjuvant chemotherapy or EBUS is still the recommendation. We need to think like this. Whenever there is a approachable thing, then we can think of EBUS. And you remember last week, Abhishek was telling that they prefer to have a bronchoscope first when it is possible. If not, then they go for central lesion FNAB. So they want to avoid that. So we need to think of the compliance and the safety and the outcome, everything. Not only thinking of one procedure. As we see, EBUS is a safe, yield is 90+%, and outdoor procedure and cheaper. So definitely, I think where there is an opportunity, we should go for EBUS. Dr. Anoda Prasad Bhai, I think you had a question. Dr. Anoda.
Thank you, Kamal Bhai. Thank you, sir, for your excellent presentation. Already, sir mentioned, my question, is there any scope to take EBUS guided biopsy?
EBUS guided by, what we do, we put the needle, and by jabbing method, we take the cell actually. It is not the junk of tissue. Biopsy, it is not a junk of tissue that is taken out from the lymph node. It is the tissue cellular materials which is taken out. So we can find out the cellular pattern from which you can find out the type of the malignancy. You can do the immunohistochemistry, you can do the other procedures. But if you tell that the biopsy, the cutting is not done here. Actually, by jabbing method, the tissue is, cellular tissue is taken by the EBUS.
If I can allow,
sir. Thank you.
Thank you. In FNSC, the amount of cellular materials is sometimes questionable, whether it is adequate or not to prepare the cell block. And cell block is a surrogate of tissue for our molecular diagnosis. I think that is your concern. But in EBUS, it is designed in such a way that it take out adequate number of cellular material, which is fair enough to create the cell block, which can do all the molecular testing, including IHC, PCR, everything. So, I mean, the challenge that we face with FNAC is not there, because this is a special design method and needle, which, as he mentioned, that it takes out adequate amount of cellular materials, which is not a tissue, but it can be representative of a tissue material. So there is still now, there is no report of any challenge that with the EBUS material, it was inadequate like FNAC to perform the molecular diagnosis. So I see there was a question from, again, Saiful Alam.
Assalamu alaikum, sir. Thank you for the nice presentation. I have a question that sir mentioned about that mostly all the nodal stations are assessed by the EBUS TBNA, but which procedure is best for the subaortic and paraesophageal lymph node assessment, which is not completely done by the EBUS, as sir mentioned? Thank you, sir.
Esophageal approach of the ultrasound. Esophageal approach can be done. Actually, we don't practice here.
So as Dr. Last said, EUS, endoscopic, even esophageal ultrasound is also something as an alternative. And for subaortic, we can do it CT guided also. We can go transternal and we can get a good window.
I think there's a question from Arman. It should be more to Ullas. Arman?
Yeah, my question is, should, as a part of the staging workup, in all situations, should we go for mediastinoscopy or EBUS for mediastinal staging in all situations before starting treatment?
Okay, so the dictum is that you have to stage the mediastinum. So what we normally, again, I'll repeat, what patients usually come to us with CT scan. We do a PET CT scan. In that, you find out that there are no distant metastatic sites. You do an MRI brain because PET CT doesn't cover the brain part of it. Now, if the lesion is more than 3 centimeter, the only place where you will not do a EBUS or a mediastinal staging is if you have a peripheral lesion which is less than 3 centimeter and the PET or the CT scan is not lighting up. Other than that, more than 3 centimeter, any lesion, even with the PET CT or CT scan being normal, you should stage the mediastinum, because you can always have occult mets in the mediastinum, even if the PET CT scan and CT scan is normal. So a peripheral lesion, less than 3 centimeter lesion, normal CT scan, normal PET CT scan is the only way you will avoid doing a mediastinal staging. For everything else, you require a mediastinal staging.
Thank you, Dr. Ullas. So, Kamal bhai, we should discuss about this matter more.
Of course. So, I mean, we can see that there is a wide range of use of EBUS, unfortunately, which we have not been practicing. We were trusting the CT scan and we are trusting the PET scan, where last week Abhishek was telling that in a fund that it is not SUV, is not a, it is a stupid uptake value, because this, sometimes we are very tempted with a very high SUV, and end of the day, it come out that it was SUV very high, but pathologically it was negative. On the other way, very low SUV, but N0 becomes 30% plus into pathological N2 in lung. So mediastinal staging is very, very important for both early and advanced stage, because in early stage, when we are taking a decision of a surgery, we need to be very sure that it was not negative, because if we knew that it was not positive, maybe we would have taken a different situation, especially for SBRT, when we are thinking that it's T1, T2, N0, but if it is really not N0, then SBRT is not effective. But if we are doing a SBRT and finally finding that it is a nodal failure, so we are making a mess. So here, these are the situation, and I think after today's discussion, we, the colleagues in Bangladesh, we understood that there is a huge opportunity to use EBUS to make our life easy and to offer a better treatment to our patient. And I'm sure many of our colleagues now will be knocking the door of our pulmonologists like Professor Ali Hossain for EBUS. And I think you need more center than one, because if we, at least the present oncologists start knocking your door, one center will not be enough. So may I ask any of the junior colleagues, do you have any other questions? I don't see any chat box, but you are welcome to ask some question. Anybody? Altaf Hussain Riyad, yes.
Thank you, sir. My question, I have 3 questions actually. My first question is, is EBUS can yield the same time, EBUS is equal to detect a central or peripheral lesion. EBUS is equal in evaluating a central or peripheral lesion.
Any role of EBUS in peripheral lesion, sir?
EBUS has got role in the basically central lesions, and some peripheral lesions can be approached, but it is mainly for the central lesions.
Okay, so thank you. My second question is, you have mentioned that in some situation, EBUS cannot yield the same like mediscriminoscopy. What are the situations?
We will mention that there are some stations where EBUS cannot be approached, cybertic, paraesophageal, but you can mediscriminoscopy, you can approach those situations. You can approach those glands also. So it is the limitation of the EBUS. Two station cannot be there. And if the person is not adequately trained, so in that case, actually, they cannot move to the other station also. Most of the actually physicians can take the samples from the subaortic hilar lymph node. But the other lymph node sometimes become difficult with the special trained, without the special trained individuals. But the paraortic, subaortic, and esophageal lymph node cannot be approached. So that is the deficiency of the EBUS in comparison to the mediscriminoscopy.
Thank you, sir. Thank you very much.
Thank you. So any more questions from the juniors?
Is it possible to show a video of the procedure?
Sir?
Will it be possible to show the video of the procedure?
Not today. Maybe we can show it another day. They have video. Sir, we will make a presentation maybe on the next week.
That will be interesting, I think.
Okay, sir. I will ask sir if him or any of his students can show us the video next week. So any more questions from the juniors? Or our faculties also, anybody? So I have a question. What is the cost of doing EBUS in our country, in a private center, sir?
It is not that much. It's only 15,000 taka.
Sorry?
15,000 taka, 15,000.
Okay. And where it is available, sir, in our country?
Actually, it is available in our NIDCH initially, but the machine is not out of order in government center. It is only available in private center, especially in one of the private hospitals. It is available now.
So initially, it was in NIDCH, but now only one private center, specialized hospital is doing it. They have the facilities. So any more question? If no question, can we move to our next session? Okay. So today our case discussion is not a very long one because I am not very familiar with this technique. So to create something on EBUS was not very easy for me, but still I tried. So who will be the volunteer? It will be more on radiology, less on EBUS, because we will discuss about the limitation of the radiology, then we will go to the EBUS. So I need a new volunteer. Anybody? Can senior help me to find out a volunteer? Asma or Lima can help me. We need to go fast.
Kamal bhai.
Yes.
Lima is in post-corona tiredness.
You want to make a question? Not you. You cannot be the volunteer. We need somebody from a student. Can you suggest someone?
Kamal bhai, Debraj কে নিতে পারেন।
Debraj তো অনেকবার হইছে, তাই আমরা চাচ্ছিলাম Debraj is there. Debraj অনেকবার বলছে। Okay, if nobody is there, we can take Debraj. Debraj, are you there?
Yes, sir, I'm here.
Okay, so we start Debraj. So we have a very, we don't have our case is not very long today. Okay, so a 65 years old man found a small shadow in the X-ray chest, just in a routine, and they found a doubtful lesion. So the doctor said that do a chest CT scan. do a chest CT scan, and chest CT revealed that there is a peripheral tumor with normal hilar and mediastinum with no distant metastasis. So what do you think you will do next? Debraj?
We could go for, as Dr. Ullash Batra was saying, as I was saying, we could go for a PET CT. And of course, some biopsy, core biopsy from the peripheral lesions.
Yes, already these things are discussed, but still it is a recapitulation that we will be, we can do a PET CT and a FNAB. If the PET CT is eliminating, then we do a core biopsy. So if the biopsy is considered of high risk for any reason, and the lesion, the material came that is a borderline situation, what can we do?
So sorry, I didn't get the question actually.
If it is the biopsy, it is a, I mean, even it is a peripheral, but the intervention radiologist is thinking that this risky. I mean, we cannot really locate from the CT scan that we can, whether we can really target it or not, and it looks like a borderline lesion. We are not sure it is malignant or not.
So we were doing the PET CT, sir, for confirmation.
We will wait for a PET CT.
Yes, sir.
Okay. So if any, in the PET CT, we find that there is a positive, we find there is a positive mediastinal or hilar node. So this happens actually when we see that there is a peripheral lesion in CT scan, there is nothing. But when we do a PET CT, it only not illuminate, but it yield a node in the mediastinum. So what should we do at that time?
So we did do the mediastinoscopy for confirmation earlier, but we for today's class we know that we can do a staging EBUS TBNA.
Yes, so we go for EBUS. So this is a situation that even in a peripheral lesion, if finally it comes out that there is a small node which is approachable, it is better to go for the nodal yield than the peripheral, because as we said, it is a peripheral tumor, small, not very confirmatory, and sometimes we may miss it. And if we miss the malignancy, we miss maybe a prospective curative disease. So we modified the case, a 64-year-old man having cough and 1 month, but no hemoptysis and weight loss. X-ray chest suspected mediastinal shadow. CT scan showed central tumor of N1 lymphadenopathy with normal mediastinum without any distant metastasis. So what to do next? Now it was a peripheral lesion, now it's a central lesion.
So for central lesion and for N1 lymphadenopathy, we can do EBUS TBNA, sir.
Yes, we can do a PET CT and bronchoscopy and EBUS staging. Remember in the last week what Abhishek was telling, when there is a possibility of bronchoscopy, he always appreciates to do a bronchoscopy rather than doing to this procedure, because they want to pick the best possible technique. Yes, EBUS is also a scope, but we should also think of a bronchoscopy when it is a mediastinal lesion. So if EBUS is negative and bronchoscopy biopsy is native pathology, what will you do?
EBUS negative, bronchoscopy also negative. So we could
so then we will go for CT-guided FNAB.
Yeah.
Because in this situation, maybe we missed it, and then we can go for, because CT, there we can more localize the CT-guided FNAB. So this situation, we asked the patient, in two situations, we asked the patient that after X-ray you do a CT scan. The patient may ask you, why we need a CT scan? Isn't X-ray enough? What can you say in favor of CT scan in chest, Debraj?
CT scan is more specific for lung lesion. Here we can identify a lot of smaller lesions than X-ray, and also the position of the lesion we can perfectly identify it.
Perfect. So provides clarity of the pulmonary abnormalities categories defined by anatomic characteristics, size, location, and extent. It is comparatively inexpensive and now it is widely available, and in combination with clinical history and examination can decide which other tests are indicated and subsequent invasive tests driven by anatomical characteristics. So then when we ask that why after CT scan we need to do a PET CT, is there any limitation of CT scan? As you said, it is better than X-ray, do many wonderful job. So what could be the limitation of CT scan, Devraj?
So PET CT, we can do PET CT for to
We
see
are talking the limitation of CT scan, Devraj. We are not going to PET CT yet.
Okay.
What is the limitation of CT scan, you think?
CT scan cannot identify lesions less than 1 centimeter, if I'm not wrong.
Okay. Anything else? Great. You have make a very good answer. Anything else?
Not actually, I'm remembering, sir. Sorry, sir.
Okay. So let me try to help you. So it delineates only the anatomy and uses 1 centimeter short axis diameter cutoff for malignancy, as you mentioned. We need to use a IV contrast, sometimes which is a bit difficult, risky for some sensitive, hypersensitive patient. And the sensitivity is 51%, specificity is 86%. And prevalence of nodal metastasis is 28%. And 40% of the enlarged nodes are benign in CT scan. And 20% of the normal sized node contains malignancy. So even it is a wonderful tool, but it is not the perfect solution for everything. Bigger the size, perfect the answer. If the size is less than 1 centimeter, metastasis is around 13%. But when the size is more than 4 centimeter, the perfection of CT scan report is 100%. So the range is from 13 to 100%. So this is the biggest challenge with CT scan. So does PET give 100% information? So we said that CT scan have some limitation. Mr. X, if you do a PET CT, you will get a wonderful result. And we suggest you spend a good amount of money and do the PET CT. So the patient will ask you that, Dr. Debraj, if I do a PET CT, can you give me 100% information? Will there be any flaws in PET CT? Is there a limitation? What will be your answer?
A PET CT may come negative for 8 millimeter positive lymph nodes. It may come positive for some inflammatory lymph nodes or inflammatory lesions. And also we have to confirm by biopsy if there is any suspected lesion.
Perfect. PET CT is not a conclusion for malignancy. Whatever we see in PET CT, final decision will come from biopsy. That is the take-home message, I think, for everybody, that whatever the illumination is, to declare a malignant lesion, PET CT is never enough. So based on biological activity on neoplastic cell functional, it is not anatomy, but no standardized quantitative criteria. Qualitative assessment of lesion against background is done, and 7 to 10 millimeter, there is a limitation, and specificity is 85%, but inaccurate up to 25% in more than 1 centimeter node. So PET positive mediastinal node SUV more than 2.5 requires invasive sampling before surgery is ruled out. So anything more than 2.5 is not a criteria to go for an invasive procedure. So now the last question, when in a suspected lung cancer patient, you will ask for EBUS. What is the indication of EBUS you think now after all the discussion? Debraj.
Indication would be for mediastinal and hilar staging before surgery. And also, as I said, there is some indication for restaging of the patient, and also some during treatment EBUS for detecting drug resistance mechanism.
Very good. So for staging, more than 1 centimeter node and more than 5 millimeter in ultrasonogram and 1 in CT scan, central tumor with normal mediastinum and FDG positive nodes. And for tissue diagnosis, serial biopsy, confirmation of recurrent disease, lymphadenopathy in extrathoracic malignancy, isolated hilar mediastinal lymph node, and parenchymal disease adjacent to major airways. So that was all for till now. Thank you, Debraj. It was wonderful. You made most of the answer correct, which was not even known to me before I prepared this slide. So now this is quiz time, and just for everybody's information, Professor Ali Hossain had to leave the session. He sent a message to chat box to all asking apology because he had another commitment. So he left us. So now is the quiz. So may I ask Samir to put the quiz link is already given in the chat box. So interested person are requested to start joining the quiz. So now we have 5 minutes time. Ullas, are you there?
Yes, sir, I'm here.
So Ullas, in our setup, as you can see that we don't have much center doing EBUS.
So sorry to interrupt, sir. It is not taking any response. The link is not taking. It said that role of EBUS TBNA and medical thoracoscopy in the management of thoracic malignancies is no longer accepting response.
Samir, problem? Can you please check? Samir?
I'm checking, sir. Just a minute.
Okay.
The same for me, sir. It is not taking up any response.
It is faced by everybody, or only Altaf Hussain Riyad is facing the problem?
So I also
No, sir,
can't
no,
log
sir.
in, sir.
Okay.
I also can't log in, sir.
Is
it okay right now?
I'm here, sir. Not reaching.
Is it okay right now, sir? Please.
Please check now again.
Yes, sir. Okay.
Is it okay? Is it okay, Riyad? So we count the time from now.
Yes, sir.
Okay. So Prabhakar Bonik raised the hands. Are you going to ask a question, Dr. Prabhakar?
No, sir, it is working now.
Okay. So Ullas, my question to you was that, as you understand, in our country, we are not routinely doing EBUS, only one center is doing it. But do you think that we are missing many opportunities to do a better treatment based on CT and PET CT that we are doing now?
I would not say really you are missing on an opportunity, sir, but I mean, definitely you start using a new thing, you will get hooked onto it. You will find out that there are huge advantages which you may get. And one of the most important thing which I feel is, sir, differentiating tuberculosis from malignancy, having N2, N3 lymph nodes, because you take up the patient for a surgery, you find out there are N2 or N3 lymph nodes and the patient just comes out. This leads to a loss of distrust and mistrust in the patient. What I totally believe is, treatment can still be okay, but the diagnostics of the patient, the correct staging workup has to be absolutely on spot. So yes, I mean, I think missing us on a good treatment is a very harsh word, but you start using more appliances and all, we will do a much better job for the patients. Patient will get benefited. That's what I would put it as.
Thanks. John, are you there?
I am, yes.
So John, is it a routine practice in your center that whenever you are doing SBRT, you are doing EBUS?
So we actually use a different technique, something called navigational bronchoscopy these days. So if we're doing SABRE for early lung cancers, we don't normally do EBUS if the PET is negative for mediastinal nodes, so we don't do routine staging for the T1N0 based on EBUS. Any uncertainty though, we would do an EBUS for anything unsure. But the beauty of doing navigational bronchoscopy is that you can, even for peripheral tumors, you can put the patient to sleep. You can deliver a fiducial into the tumor, even at the very periphery of the lung. You can sample the tumor as well. And essentially it helps us avoid CT-guided biopsy, which can, of course, lead to pneumothoraces. And some of these patients, as I'm sure you know, if they do develop a pneumothorax, their lung function is so poor that it can be a life-threatening complication.
Thank you, John. I mean, this is one very interesting, important point I would like to discuss, draw the attention of my juniors, that in our country, the practice of pulmonary function in lung cancer assessment is not very popular. But whenever we are doing for radical radiotherapy, but not for surgery, it is so critical because what we are doing radiation is something like surgery. So if we are not knowing about the reserve of the lung, so after radiation, maybe we can cure him from the disease, but he will be suffering whole his life with the less reserve of lung. So it is equally important when we are doing a radical radiation to assess the function. And why I asked him, because yes, when it is PET negative is fine, but sometimes, you know, it is a T1 lesion, very tempting, 3 centimeter lesion, maybe T2 lesion, but no nodes, but PET CT is showing slightly area, which is very doubtful. Nobody can really say it is yes or no. So very tempting at this moment to go for, you know, the SBRT, because hardly we get a patient of SBRT. So that's why I think those are the serious situation. And today I was really horrified to see that N0 disease comes out 32% PN2 in surgery. So this is a real horrifying picture. That's why what Ullas was telling, not to use a harsh word, but we should start doing it so that maybe we will not be missing, rather we will be seeing many more information, getting more information before going for treating. Ullas, regarding the early stage, you said about the EBUS. Any role of EBUS in advanced stage, do you think?
So, sir, I mean, what we normally do is, let us say somebody comes to us with a metastatic disease, and we are not sure. I mean, so, I mean, let's say somebody has a single oligometastatic site with a brain met, and we want to, so single brain, single lung, and maybe some medicinal lymph nodes are there. So let's say if you prove out the lymph nodes are there less than N2 disease, we can go ahead with a definitive curative treatment for both the brain and the lung. So, you know, even a stage 4 oligometastatic disease can be used for that. But generally, if you have proven, and again, you know, there's so many times we have got tuberculosis, sir. I mean, you know, a PET scan classically showing that this disease here. I just recently, we had a patient of ovarian cancer. You know, a lady came to us with ascites or mental thickening, had some lymph nodes in the subchondral region. We got an EBUS and that came as granulomatous lymphadenitis. We gave AG to that patient. The patient is absolutely okay. You know, I mean, and these are the things which put you, which make you a believer. So I have had a very huge. So your respiratory team, your ancillary team, you know, what you said was absolutely right. Cancer is not about me. Cancer is about a team. I feel I am more useless as compared to what my IR team, Abhishek is there, my pathologist is there, my respiratory team is there. I just take the credit out of it. They do all the hard work. And I hope Abhishek is not listening to this.
Thank you, Ullas. And as you mentioned regarding the CO ovary, that you see, it is funny that CO125 is also raised for tuberculosis. So sometimes with the raised CO125, with all the pictures, CT scan looks like there is a, you know, the ovary type of thing. And we are very charged that it is a malignant ovarian malignancy. C125 is quite rise, but finally it comes to be a tuberculosis. It happened, and we should be very cautious, because one case in life is enough to spoil everything, because there is no rationale of giving paclicarbo to a tuberculosis patient. It will not.
In fact, I would like to tell you, sir, you know, how we started was, I think Abhishek will remember, I mean, some 5-6 years back, you know, we also were not a believer. It was a classical lung cancer on the thing. And our surgeon went ahead and inside and, you know, he got it operated and it came out to be tuberculosis. Oh, we had such a loss of face over there. You know, what would we tell the patient? What would they think? If and, you know, medical legally, are you right? You're not. I mean, so, you know, as you rightly said, sir, one case is enough to open your eyes. And as doctors, it is our duty to help the patients first. It's the patient first approach. It's not me, it's not someone else, it's the patient first. That's what I always believe in.
Yeah, here I want to add one thing, that personally I had a few experience that once we find a tuberculosis in lung, and before we had some evidence of lung cancer, we should not stop searching, because it is rare but possible to coexist both. Yes. So we want to see the good news. So once we see there was a lung cancer, then we find a tuberculosis, we become so happy, as if that there is no chance of getting lung cancer. So that is
can I come on that also, sir? So again, we have got 3% of our people who have got both tuberculosis and cancer. My standard answer to them and advice to them is that take ADD for 4 to 6 weeks. Please repeat a CT scan chest at the end of 4 weeks and come back and show me. so that you're not missing a indolent lung cancer or coexistent lung cancer in that. That has also happened by, again, it's of personal experience that I'm speaking about. So there was a guy with tuberculosis. We said, okay, go and take this. She came back after 6 to 8 months and there was a huge disease. So I always tell them to come back to me.
Okay, so if a patient Ullas comes with both,
so I think Abhishek has a point, sir. I think Abhishek also have a point.
So like last sir said, sir, we have had a series of patients where the characteristic appearance was a miliary tuberculosis,
yes,
and all of them turned out to be cancer, sir.
EGFR mutant, Abhishek. On top of that, I have 7 people like that, you know.
Yes, sir.
So say Ullas, you have a patient diagnosed as lung cancer. Then we found out that there is a tuberculosis also. So what will be your take? Will you be treating TB, lung cancer together sequentially?
So sir, we as a rule start ADT for 15 days. So if the patient has not been diagnosed, we do all the biomarker workup in those 15 days. After 15 to 20 days, we do a LFT once again. And you know, it takes only 15 days for the AGT to you know, for the virus to get reactivated. And then we can start with anti-cancer treatment, if it's chemotherapy.
So what about the tuberculosis? You don't treat for the tuberculosis?
No, so we give ADT, sir. ADT goes on together.
Okay,
so start with ADT, review after 2 weeks, start anti-neoplastic therapy.
So this is a message I wanted intentionally to bring up to our colleagues, junior colleagues, that many people think that we need to take care of the cancer first.
No.
So that is a danger, because tuberculosis is sometimes more dangerous than HIV. You remember, Americans were very keen about tuberculosis when HIV became prevalent, because due to the immunosuppressed situation, TB is more dangerous than HIV. Similarly, in a lung cancer patient, if we give chemotherapy and may make the patient immunosuppressed, then the TB may become a killer. So we need to address both. And as you heard from him, we can treat both the disease together. There is no harm on treating both the things together. So we move to our next session. I need another volunteer for our rapid fire session. Sorry for the time. Okay. So I need another volunteer for the rapid fire session. Who will be the volunteer? Already we have the quiz winner name, but we are not going to declare it. Anybody?
Sir, Saiful Alam Kajol.
Saiful Alam Kajol. Okay, Kajol. So here is the first question for you. So what is the radiological normal mediastinum? When you will say that it is a normal mediastinum in comparison to lymph node radiologically? You do a CT scan and you say it is a normal mediastinum. What are the findings you will find?
Sir, lymph node less than 1 centimeter in diameter, I will consider as normal.
Yes, very good. And if it is a CT scan less than 10 millimeter, and if it is a PET scan, there is no uptakes, then it is a normal mediastinum. Very good. So is there any recommendation of doing mediastinum lymph node sampling in N0 disease?
Sir, there is a recommendation, because I know that if it is stage 1 and 2 with node negative patient, there is still chance of 15% of lymph node positivity when there is surgical lymph node dissection.
Dr. Saiful, it is radiologically N0.
Sir, sampling can
be comment. Unfortunately, even you are correct. There is a chance of pathological in positive, but current guideline, if radiologically it is N0, both CT and PET CT, as Dr. John Coniver was telling, we are not advised to do for a mediastinal lymph node sampling. So what is the treatment of choice for a N0 and N1 disease? Definitely M0. So T3 N0 or T3 N1. What will be your treatment?
Sir, surgical resection of the tumor will be my first choice if there is
Surgical
N0.
resection is the treatment of choice. 100% correct, Saiful. So how many percentage of PN2 is seen in clinical N0 disease?
Sir, I'm not sure.
So let me help you. 0 to 10, 10 to 20, 20 to 30. Or more than 30. Guess.
Sir, I
It's
think
around
more than 30.
35%. Unbelievable truth is it is around 35%. So which is the most common station that is upstage in clinically N0 situation? Any idea? So let me help you.
Sir, hilar lymph node.
Upstage is 4R and
Oh,
7.
sorry, sir.
And the good thing is that these stations are
Lower
easy to
paratracheal and
by
subaortic.
EBUS TBNA.
EBUS TBNA. Yes, sir.
So what is the sensitivity and specificity of EBUS TBNA?
So sensitivity is 96% around and specificity is 100%.
So, okay. So I think it was wrong. It was 94. I made a mistake, 49. Okay. How to assess the medicine after neoadjuvant treatment? What is the sensitivity specificity EBUS TBNA combined with US and USFNA? So first answer, how you want to assess the medicine after neoadjuvant chemotherapy?
Sir, I want to do is CT scan of chest.
It is doubtful. You are not sure.
Sure, sir.
So then we can do a EBUS TNA, and it is a standard protocol that after neoadjuvant chemotherapy, if you are not sure about because you want to do a surgery, you want to know about the nodes, it is doubtful, then it is recommended you should do a EBUS TBNA. So what is the sensitivity and specificity of EBUS TBNA for N2 and N3 disease? That we discussed was N0 and N1.
Yes, sir, no idea.
100%, because more the node, bigger the node, bigger the size. So what is the limitation of medistinoscopy? This is the last question. You have done wonderful.
Sir, it is an invasive procedure and requires almost general anesthesia. Complications are and all lymph node station. All lymph node station are also not seen by the medistinoscopy.
So only 2 LR and 4 LR can be sampled, whereas 10 LR, 11, 8, 9 cannot be sampled. It was general anesthesia and it is an invasive procedure. So that's all. Thank you. Thank you, Dr. Saiful Alam Kajol. No?
Yes, sir.
So is there anybody from Roche today with us? So we are grateful to Roche, our academic partner. Thanks to Roche. And now we need to see who is the winner. So before going to the winner, our next week session is on role of surgery in thoracic malignancy. Our speaker will be a young thoracic surgeon from NIDCH. His name is, we know him by name of Shakil. He is a very young, enthusiastic surgeon. He will be talking on the role of surgery in the management of lung cancer, what oncologists need to know. And now we come to our today's prize winner is Dr. Debraj Chakraborty. Congratulations, Debraj, you have scored 80 out of 100.
Thank
so
you,
congratulations to Debraj. So Debraj is also having a habit of getting the quiz award. So
Second time, sir, only.
Second time?
Yes, sir.
Okay. So maybe next time also. So congratulations to Debraj. So I think today we are a bit fast. We are ahead of time. So if we have nothing more to discuss, we can end up the session. I want to thank all of our today's presenter and all the foreign faculties who have sacrificed their holiday and all our participants. And the discussion was great. So now may I request, if nobody have any comment, may I request Professor Hai to conclude the session.
Thank you, Kamal. Next question we have
Sir?
Debate. Next Tuesday we have debate on.
Yeah, sir. That is, we have a session on gyne-oncology. Oncologists are requested to join. You will have the invitation by today, and you are requested to participate. There will be alternative journal club and tumor board, and the tumor board there will be debate. So all of you will get the invitation and requested to join at 9 p.m. local Bangladesh time, 9 to 10:30 on Tuesday. It will be a dedicated gyne-oncology session on the gyne-oncologist and the radiation oncologist interested in gyne-oncology are requested to participate. Sir, would you mind to finish it?
Okay, thank you. Heartfelt thanks to everybody for joining and having a nice, fruitful discussion and lively discussion. Thank you all very much. I'd like to see you again next Sunday. Okay, goodbye, everybody. Alhamdulillah.
So thank you very much, and thanks to all the foreign faculties. Hopefully, we'll be seeing you again. John, again, invitation for next week. Ullas, again. And Abhishek, be a regular participant. We will enjoy your participation. You will have some opportunity to talk on the surgery portion, I'm sure.
Thank you, sir.
So thank you very much.
Thanks all.
Bye.
Thank you.
Bye-bye.
Thank you, sir.
Okay,
Sir,
thank you,
I'm ending the
everyone. It was
session.
great having you all here. Thank you.
Bye-bye, everybody.
Sir, I'm ending the session.
Okay.